All right, today we're jumping into one of the most feared diagnoses in all of medicine, bacterial meningitis. And let me be clear, this isn't just a serious condition. It's a full-blown neurological emergency where every single second, literally every tick of the clock counts. So, let me ask you a question just to frame our thinking here. We all get headaches, right? But what is the single most dangerous headache you can possibly have? Well, while a lot of things can cause a really severe headache, the one you absolutely cannot afford to miss is the one that's signaling an infection raging around the brain and spinal cord.
So first things first, we really need to get a handle on what makes this specific infection such a massive threat to our central nervous system.
Okay, so what is it? Bacterial meningitis is an infection that causes this massive inflammation of the meninges. And the meninges are basically these protective membranes, kind of like a 3-layered blanket that cover your entire brain and spinal cord. The analogy here is perfect. It's like a fire breaking out in the brain's security system. This isn't just an infection near the brain, it's a direct assault on its primary defense, creating absolute chaos from the inside out.
So how does this fire even get started? Well, it's not random. It's more like a planned 4-step invasion. First, some pretty common bacteria set up camp in the back of the nose and throat. That's colonization. Next, they break through the local defenses and invade the bloodstream. From there, it's a battle for survival as they have to dodge and weave through our immune system. And then, the final devastating step, they breach the fortress. They cross the blood-brain barrier and get into the fluid that circulates around the brain. And once that happens, the infection is on.
So if this invasion is underway, how do we spot it? This is where we have to become detectives. We've got to learn how to recognize the red flags. If you think of meningitis as a crime scene, the symptoms are the clues. And spotting those clues quickly can literally mean the difference between a full recovery and a total catastrophe.
And here are the key clues you've got to look out for. A severe headache is really common. A high fever and a stiff neck, a sign we call meningismus. But you also have to watch really closely for any change in their mental status. Are they confused, out of it, just not themselves? On top of that, you get extreme tiredness, nausea and vomiting, and in some cases, a very, very specific type of rash. Now, this next point is absolutely critical to remember. We often hear about the classic triad, that's fever, neck stiffness, and altered mental status. But look at that number. It's only present in about 40% of patients. That means if you wait around for all 3 signs to show up, you are going to miss this diagnosis most of the time. The absence of that full triad does not mean the patient doesn't have meningitis.
And speaking of signs, this one is probably one of the most terrifying. This is a petechial or purpuric rash. A key feature is that it doesn't fade under pressure. If you press a glass on it, you can still see it. This is a hallmark of meningococcal disease, and it means the bacteria are running rampant in the blood. When you see this, especially if it's spreading quickly, you are in a time-critical life-or-death emergency. Now, let's talk about a couple of classic, but frankly less reliable clues. You'll see Koenig's and Brzezinski signs in all the old textbooks. They're these physical exam maneuvers that check for meningeal irritation. And while they're historically important, we now know they have very low sensitivity. In plain English, that means they're often absent, even when a patient has meningitis. So you really can't use them to confidently rule the diagnosis in or out. So if some of the initial clues can be a bit misleading, how do we get a definitive answer? Well, to really crack this case, we have to turn to the lab. And we have to do it fast. The sequence of events here is absolutely vital. You cannot get this wrong. First, you draw blood cultures, ideally before any antibiotics are given. Second, if it's safe to do so, you perform a lumbar puncture or an LP to get a sample of the cerebrospinal fluid. But the most important rule of all is step 3. Do not delay giving antibiotics. If there's going to be any kind of delay in getting that LP, you give the antibiotics immediately after the blood cultures are drawn, period.
That lumbar puncture provides the smoking gun. In bacterial meningitis, the cerebrospinal fluid tells a very clear story. Instead of being clear, it looks cloudy. The opening pressure is high, it's swarming with thousands of immune cells, mostly neutrophils. But the 2 key chemical clues are low glucose, because the bacteria are literally eating it, and super high protein from all the inflammation.
And this is where we get our first look at the enemy. This is a gram stain of the CSF. Those little purple dots arranged in pairs, those are gram-positive diplococci, the classic appearance of Streptococcus pneumoniae. This is an incredibly useful, rapid test that gives us a huge clue about which specific antibiotics to use while we wait for the final cultures.
So who are the usual suspects here? Well, in adults, Streptococcus pneumoniae is number 1, the most common overall. Number 2 is Neisseria meningitis. That's the one we often associate with that dangerous rash. And then there's another one we always have to think about, Listeria monocytogenes. This one is more common in adults over 50 or in anyone with a weakened immune system.
All right, we've identified the enemy. Now it's time to fight back. This brings us to treatment, which is truly a race against the clock. In neurology, we have a saying, time is brain, and nowhere is that more true than in this disease.
This right here is the single most important message of this entire explainer. Treat first, confirm later. If you have any suspicion for bacterial meningitis, you must start antibiotics immediately. Any delay, waiting for a CT scan, waiting for a difficult LP, is associated with worse outcomes, including permanent disability and death.
So what does that initial treatment look like? Well, we choose our first-line antibiotics based on the most likely culprits for that specific patient. For a healthy adult under 50, you'll start with ceftriaxone plus vancomycin to cover the 2 most common bacteria. But if the patient is over 50 or immunocompromised, you have to add ampicillin to cover for listeria. And for patients who've had recent neurosurgery, we use even broader antibiotics to cover for bugs like MRSA and Pseudomonas.
Now, besides the antibiotics, there's another crucial medication we use, dexamethasone. This is a powerful steroid. Its job isn't to kill the bacteria, its job is to calm down the massive, out-of-control inflammatory response that the infection triggers. It's often that inflammation itself that causes a lot of the permanent neurological damage, especially hearing loss.
But using steroids comes with very specific rules. The timing is absolutely critical. You have to give it immediately before or at the same time as the very first dose of antibiotics. If you give it after, it doesn't work as well. We generally continue it if the bug is S. pneumonia, since that's the one that causes the worst inflammation. But if we confirm it's another cause, we usually stop the steroid, since the benefit isn't as clear.
Okay, so winning that initial battle is just the beginning. For our last section, let's look at the potential long-term consequences. And, just as importantly, let's talk about how we can prevent this devastating disease from happening in the first place.
The aftermath can be severe. Even with fast treatment, patients can be left with permanent complications. Hearing loss is one of the most common. But we also see cognitive problems, new-onset seizures, paralysis, and in those really terrible cases of meningococcal disease, even limb amputations. This is why we treat so aggressively from the very start. Thankfully, we have powerful tools for prevention, which really rest on 3 pillars. First, for patients with suspected meningococcal disease, they're placed on droplet precautions in the hospital to prevent spread. Second, close contacts, like family or roommates, are given preventative antibiotics. And third, and most importantly, vaccination remains our absolute best defense against the most common causes of bacterial meningitis. This quote from Dynamed really says it all, doesn't it? Prompt diagnosis and management are critical to avoid substantial morbidity and mortality. That's been the central theme of this entire discussion. It's a simple sentence, but man, it carries the full weight of this disease. And so we end where we began, with a question. But this time, it's for you. Bacterial meningitis is a formidable opponent, defined by its incredible speed and severity. You now know the clues, the diagnostic steps, and the absolute urgency of treatment. So the real challenge is putting all that knowledge into action. Now that you know the clues, will you recognize the red flags in time?